Today we are going to be talking about devices. So very basic about pacemaker implants and how to do follow-ups. And we have Dr. Park with us. He has introduced himself. And we have Dr. Malik with us, a new friend. Dr. Malik, would you like to introduce yourself?
Yeah, I'm Dr. Amit Malik from New Delhi, India. Did fellowship in EP and arrhythmia, National Heart Center 2010. And after that, I'm practicing here in New Delhi, India as Associate Director, Cardiac Science in Max Hospital, Delhi. Dr. Park, please.
Oh, I'm Dr. Park, working for Samsung Medical Center, Seoul, Korea. I'm electrophysiologist. I'm particularly focused on cardiac device implantation. I'm performing implantation of many kinds of cardiac device and also performing lead extraction as well. I'm very happy to join this meeting.
Okay, then I will do the first presentation. Then Miss Sui, she will continue with follow-up after that. Sui is a dear colleague of mine. Yeah. You want to introduce yourself?
Hi, I'm Shufen's Junior. So I'll be doing a talk on how to do a pacemaker check in clinic. Yeah, back to you, Shufen.
Okay, I will start with very basic how to do an implant. When I started doing EP and we had to learn implants, that was quite a while back, and we don't really have a lot of resources on how to do implants. So that's why I think I want to share about what I learned. So what are some of the indications for implants? Usually the patients will come in with AV nodal disease. So they might have complete heart blocks. Oh. Sorry, am I sharing my screen yet? No.
No.
Sorry. Share.
Yeah, sure.
So they might come in with AV nodal disease, so present with complete heart block or high-grade AV blocks, and then you have your sinus node dysfunction, which they get pauses, and they will faint or they will feel giddy, or they have symptomatic bradycardia. So then we have to choose whether we want to put a dual chamber device or a single chamber device. So usually the doctors might be the ones that select the devices, but nowadays usually we do put in a dual chamber device for the patient, unless of course they have permanent AF, then a single chamber device would be chosen for them. Okay, so come to the very technical part of an implant. For me in our lab, usually before we start an implant, I will prep a trolley with the accessories that we need. So here we have the programmer with the analyzer, and we will take usually a few devices which we might need for the implant and leads. And usually I'll prepare a few lengths because you might not know how tall the patient might be, or if the heart is quite dilated, then maybe you will need a longer length for the leads. So usually they come in 3 lengths, or they might be even longer ones, which you have to specially order. Then you have sheaths for you to do puncturing for the vein and to allow the leads to access the vein. And you need a testing cable to be connected to the leads and the analyzer to look at the electrogram. Okay, so preparing the patient for the implant, we put on ECG. 12-lead ECG is not necessary unless you are doing case bundle pacing or you want to do CRT implant. So a 5-lead ECG is enough. Then in our lab, we put on the defib pads and the ECG from the defibrillator. This is just in the event that usually these patients come in, they might already have ventricular standstill and fainted out of hospital. That's why they are coming into the lab to do implants. So it might happen to them when we give sedation and all that, the rate might be too slow and we might need to pace externally using the defibrillator. And they can also go into VT or VF. It can be bradycardia or pulse-induced start. So we might need to shock the patient. So be prepared for anything when you are doing an implant. And of course, we put on the BP cuff and pulse oximeter as sedation is given. And we need to check the BP of the patient frequently and to make sure the oxygen saturation is enough. And we make sure that the venous plug is usually on the same side as the device pocket. So usually we implant on the left pectoral, so on the left hand. If the device is to be implanted on the right side, then we would put it on the right hand, the venous plug on the right hand. So this would make it easier for the doctors to do venogram during the procedure and then to connect a drip so that the vein would be easy to access. So, and of course, we have our device trolley prepped already, so we can continue with the case. So the doctors will start off the procedure by creating the pocket, the subcutaneous pocket, usually created with a sharp and blunt dissection. And the size of the pocket, of course, depends on the size of the device. It shouldn't be too big or too small. So sometimes, because there's so many varieties of devices, ICDs and CRTs, they might want to look at the size of the device before making the pocket to make sure that it's adequate. So they might ask to look at it. So you can just, if there's a sample of the device, then you can show, or you can just open the package, but not the sterile part, just to look at the size of the device. Okay, so when the pocket is created, then we can do the puncture. At this point, I would like to say some doctors might want to do puncture first before creating the pocket. So this is really up to the doctor's preference. But in our lab, usually we create the pocket and then we do the puncture. And there are a few ways for puncture. You can puncture the subclavian vein or the axillary vein. And I'm not sure now anybody still do Catholic cut down technique. In previously, we have a few doctors who do. It takes a longer time, which I'm not sure why. Maybe the doctors can explain later. But now mainly all our doctors do the subclavian vein puncture. Yeah. So this is how they might access. On X-ray, look at the clavicle and the first rib, and then they will puncture around here. So some doctors might also do venogram to visualize the passage of the vein to help in their puncture. Okay, so this is a successful puncture with the guide wire going down the subclavian vein into the SVC and then into the heart. Okay, so after we have access in the veins, we can put in the sheaths and then position the leads using the stylet. So sometimes you might need to take note of where the lead is positioned. So in LAO, we can see whether the lead is towards the septum or on the lateral. Usually we want it, not usually, we want it to be on the septum. And in RAO, you would see how far into the ventricle it is. So whether is it in the middle of the RV, so mid septum, or in the apical portion, or if it's higher up, maybe in the RVOT portion. then we can use X-ray to confirm whether the screw extension is adequate when they have decided to deploy. And so during implant, usually we position the RV lead before the atrial lead. Yeah. And when the lead position is okay, we will screw, the screw at the tip will be deployed. And usually we would want to have 2 screws out. And different manufacturers actually have a certain number of turns that fully deploys the screw. Yeah. So you shouldn't overextend or underextend. So if you didn't deploy enough, it might lead to dislodgement. And overextension might damage the lead. So we should just give an adequate number of turns. Okay. For the atrial lead, usually it's placed in the right atrial appendage. And from this anatomy here, you can see actually the right atrial appendage is quite close to the outflow tract. So that's why sometimes you might see far field ventricle signals. And if the lead is too far into the appendage, just be careful that there might be perforation. Okay, so after the leads are deployed, what we want to do, we can do it very systematically. So we want to check the sensing to make sure that whatever the device is seeing is enough and is seeing what we are seeing. And then we want to check the impedance. So I would always think of this as in like an electrical circuit. The impedance should be within limits. It shouldn't be too high or too low. So the circuit should not be broken. Yeah. And then we want to check the threshold to make sure that it's enough, hopefully as low as possible, to extend the longevity of the device. And then lastly, to check for diaphragmatic stimulation. So after the lead is deployed, we can check for sensing. So here, I'm using a St. Jude, now known as Abbott, analyzer from Abbott. So here you have the ECG, so you have the markers here, and then you have the electrograms. So it's telling me how tall the R waves are from the RV lead. So they should be more than 5 to allow adequate sensing. You don't want it to be too small to be sensing noise or far field signals. And then we want to look for current of injury. When I started doing implant, a lot of people tell me, look for a current of injury. So I was always thinking, what was that? So current of injury would be similar to an ST elevation. So what we want to look for is an increase in height and duration of the ST segment. So if this is the baseline, after you screw in, this would be what you want to look for. An increase in height and then a longer duration compared to baseline. And after the injury has subsided, it should go back to normal. So what you don't want would be a negative injury pattern, which would be like an acute injury. This could be an indication of perforation. And in this paper that I found, they had an acute injury after screwing. And after they retract the screw and withdraw back, the injury became upright, the normal current injury. So they were suspecting there might have been some perforation in this case. But of course, if you see this, don't panic yet. Check to see your positive, negative clips are not clipped wrongly. And then if they are correct, then probably retract the screw and then reposition. So after we have made sure the sensing is adequate, we want to make sure the impedance is fine. Impedance can only be checked when you have turned on pacing. So we start to pace, and then we look at the measurement of the impedance. It should be within range of 300 to 1,500. If it's out of range, example, if it's 1,500, so that means there's a broken circuit somewhere. So inadequate contact with tissue by the lead can cause high impedance. So maybe there's not much contact, the screw didn't screw in well into the myocardium, so maybe we need to retry again. Then of course, we do our threshold check. Okay, we want to make sure there's consistent capture. So on the analyzers, usually they have a test run for the threshold. So you can just put it on, and then you can start pacing. Usually we start at 5 volts and then come down. So you want to make sure there is consistent capture. So at 2 volts here, there is consistent capture. And then at 1, consistent capture. And at 0.9, there is a loss of capture. So loss of capture, you can see on the ECG, there's no QRS. And on the electrogram, there's a pacing spike, but there's no what we call evoked response on the electrogram. So loss of capture or the threshold would always be a consistent capture at the output. So even if there is intermittent capture, we would say the capture has lost. We always want a consistent capture for it to be considered the threshold for pacing. So after that, we would want to check for phrenic stimulation. When we pace at high output 10 volts for the RV, we probably want to check for perforation rather than phrenic, because your RV, below your RV is just your diaphragm. So if you have perforate through the RV, you're probably going to pace the diaphragm, which causes diaphragmatic stimulation. So I've never seen it happen before. Yeah, so many years doing cases, but still we always check. For your RA, we want to check for phrenic stimulation because the phrenic nerve runs right about there, but it's probably more posterior. Okay. So after we have finished checking the leads and we are happy with where the leads are, they will be sutured to the tissue. And then the pacemaker pocket is, in our lab at least, we will irrigate with antibiotic solution, usually gentamicin. And then the device gets connected to the leads using a wrench, and then the pocket is closed. These days, if the patient is diabetic or has a long hospital stay, we might even use antibacterial envelope. I'm not sure if it's available in the other countries, Tyrex by Medtronic. So yeah, to prevent infection. So here we have some of the acute complications that we might see during implantation and post-implant. So you can have pneumothorax, which during the puncture, there's some puncture into the lung, so you might get air into the lung or blood in the lung, and then cardiac perforation from the atrial lead or the ventricular leads. Or if the patient has AF and is on anticoagulation, then you can have pocket hematoma, and if it's too big, then it might require intervention. But some doctors might be more conservative and want to let it subside by itself. So this is a picture of the hematoma here, and then you can have lead dislodgement. That's why usually post-implant, the next day, we would do an X-ray and then a device check for the patient again. And of course, infection. So usually I would tell the patient next day, if I'm doing a post-implant check, for them to be very careful of the wound, not to get it wet, and generally just be careful. Yeah. So yeah, this is our lab This is our old lab actually. Dr. Malik, we have moved to a new lab, so you can come and visit our new lab. Oh, I think you have came. Yeah, so this is our team, and that's my talk for today. Very short and simple, I hope. Thank you. So any questions?
Yeah, I think, Shufan, you have elaborated the steps very nicely and very systematically, right from the patient preparation up to the patient coming out of the cath lab. I just want to add few things. Suppose if you are doing a pacemaker and patient is on the temporary pacemaker already because of the complete heart block. So before starting the procedure, one should check the lead, deep temporary pacing lead and the threshold so that you won't have any problem during the permanent pacemaker implantation if pacemaker patient is dependent, one thing. Another thing is that, yeah, if and checking the coagulation parameters is very important for all the tech and nursing staff before taking these patients to the cath lab, especially the INR value and the platelet count and the APTT value. The third thing is most of the time now we are having the patient who come for the pulse generator replacement, either for the AICD or for the pacemaker. So if a patient is dependent, one should be careful to look that most of the time many operators they are use cautery. So switch the device to at least asynchronous mode during the short procedure, or for AICD at least switch off the device during the procedure. And one thing very important you elaborated at the end of the procedure, one should look for the pneumothorax. This is a very, very important observation, I think, from everybody who is presenting or supporting the case at that time, because you can detect this complication then and there only on the table if you are vigilant enough. And that can avoid an unnecessary major complication later on. Nowadays, as you said, that cephalic vein cut down is very low. It's true, because I think in the people who have started practicing in last 2 decades, they are more trained to do the subclavian puncture, and especially as you describe in your talk very nicely, the anatomical landmark of the first rib. So if you are careful to do the extrathoracic puncture, that you do not go beyond the first rib, the chances of pneumothorax are very, very low. But yes, things happen sometimes in the cath lab. So at the end of the procedure, the last fluoroscopy should be for the lead position as well as for the pneumothorax. So one should be very vigilant for that. I think this is a fantastic presentation, a very systematic presentation by Sufid, and congratulations for preparing such a nice talk and in such an easy manner, step by step, that a person who is supporting in the cath lab, whether it is a technical staff or the nursing staff, they should be aware of all these parameters for a safe procedure. Up to you, Dr. Park, please.
Okay. Can you hear me?
Yep.
Yeah, you can.
Okay, so I'm afraid because my internet connections become a little bit unstable. Anyway, very good presentation, Miss Shen Fan Yang, very nice. Okay, I'd like to give some comments regarding the pacemaker implantation. The first one is the subclavian vein punctures also. So we also try to two medial punctures, because two medial side puncture can cause lead fractures, not only pneumothorax, because pacemaker lead can need to cross the between the space between the first rib and the clavicle. So if we make a puncture too medially, so pacemaker lead can squeeze between the two bones. So we always try to make a punctures as laterally as possible to avoid the lead friction between the two bone structures. So this is one of the most important another more important point when you make a punctures. So, and the second one is the we need to pay attention to the QRS vector on the 12 standard ECG after finishing the pacemaker implantation. Sometimes we pacemaker lead can across the septal, for example, through the ASD or foramen ovale, PFO, patent foramen ovale. So X-ray fluoroscopy can mislead us to the misunderstanding, misinterpretation. So we need to check the 12 lead ECG. So for example, when pacemaker leads across the ASD to the left side, QRS vector in lead 1 and appear negative, and QRS vector on V1 precordial lead shows the positive QRS vector. So when we see the positive QRS vector on V1 or negative QRS vector in lead 2, when pacing, we check the fluoroscopy carefully and ARAO and RAO. So we check whether the RV lead implanted the left side. So, and if they really go through the LV side, we change it the pacemaker site. This is the I think the one of the most important point after the implantation.
Yeah. Okay, we
Very
have.
valid. I think, Shufin, we have a little bit, I think, 2 questions from the audience. Quickly, we will take it.
Okay,
so one has asked that, did you perform venoplasty sometime? I think quite a valid question. Sometime when you do the venogram first and you couldn't find a great vein, especially in my experience, it happened if the patient has got a dialysis catheter in the past, or sometime a long internal jugular line because of some critical illness. Sometime we got this stricture in the subclavian and brachiocephalic part, and we need to do a plain balloon angioplasty on a very low pressure sometime to do this.
Oh, you do? We haven't. We would just switch to another side.
No, that is why I'm saying that sometime with the patient of the renal failure, they are on dialysis. On the other hand, there is fistula, so you can't use that subclavian vein. So you left only with the one on the one side. So this situation has happened sometime. I think Dr. Park have agreed that he might have faced such such.
Do
problem.
you use Micra?
No, most of the time, this is open by just low pressure plain balloon angioplasty. You just do this, make a way quickly, and the lead will go. Most of the time, there is no problem.
So for us, if the veins are not available at the upper part, usually we have leadless pacemakers here, so we would put leadless.
Yeah, it happened, but there is financial constraint sometime.
In our region, yes, I understand.
Yes. Okay. Actually, I agree with Dr. Malik, because venoplasty usually very safe. Very safe. So we can perform successfully venoplasty using peripheral balloon. Coronary balloon is very small. So peripheral balloon has a big diameter. It's very useful to make using the to perform venoplasty around the central vein for subclavian area or innominate vein area, or sometimes SVC. So one of the very useful point is this, that block the degree of block of central vein looks more severe when we perform a peripheral venogram. So central venogram is more useful because even if subclavian vein looks totally obstructed when peripheral venogram, we usually perform one more time using the central vein. So when we perform central venogram one more time, we can frequently find some channel on the block site. So we can come across, we can put the wire, a pteroma wire or coronary wire through the small channel, so we can perform venoplasty. So that kind of channel cannot be visualized from peripheral venogram.
Yes.
Central venogram very useful to find the small channel.
Yeah,
Mm.
yeah. So very important tip. Yeah, very important tip. Thank you, Dr. Park, for this.
Wow, that's something I learned.
Yeah, Shubhen, one more question for you, I think. Yeah, one audience has asked that, do you check sensed P or R wave or slew rate? So I think you have already explained for that. Just answer once more. For slew rate.
Slew rate. When I started doing implants, actually I do look at the slew rate, but and they were saying if it's a sharp deflection is good, but I've never really understood why. So nowadays I will look for if the electrogram is big enough, and I look for the injury pattern. So because it would show the stability of the lead and how good in contact the lead is with the myocardium. Yeah, I have to admit I haven't paid much attention to slew rate. How about the doctors? Do you look at it?
Dr. Park, your comment, please.
Yeah. Sometimes we check the slew rate, especially when it is very difficult to find a good place with a good signal, good amplitude. When we cannot find a good implant site which have a large enough amplitude, at that time we check the slew rate. If slew rate is okay, we select that implantation site.
So that is an additional parameter to look at. Sometimes it would be helpful, I think.
Have you guys ever encountered when you were doing an implant and the injury pattern is huge, and the RF measurement is good, let's say 10, and after you're connected to the device, before you connect, as the procedure goes on, you check it again, and then it suddenly drops to 4 or 3. Do you reposition the lead?
I think if you are not happy with the final parameter, Shufin, before screwing the lead to the device, it is the right time to reposition it then and there only, rather than reopening the entire device and pocket and make the patient more vulnerable for infection.
Yeah. Okay. Should we go on to the next presentation?
Yes.
Sweet.
Thank you. So I'll be coming to my part of presentation on how to do a implant, how to do a pacemaker check in office. Okay, so sorry, give me a moment. I'm still trying to figure this out. Can you all see my screen?
Yep.
Okay. And okay, is this okay?
Yeah, it's fine. Perfect.
Okay. So hi, good morning. So I will be sharing on how to do a pacemaker follow-up check during the clinic. Thank you, Shufar, for the wonderful talk. So this is a brief outline of my talk. It will just be talking about doing the test on voltage, battery check, lead impedance, sensing and threshold, as well as recognizing some of the common problems faced during a pacemaker check and how do we troubleshoot them. Okay, so step one, I will always evaluate the patient's presenting rhythm when I interrogate the device. So some of the common questions that I ask myself is, what is the current mode right now the patient is in and the rhythm? And is it pacing primarily in the atrium or ventricle? So using this example of a dual chamber pacing, there are 4 combinations of pacing as shown above. So it's important to recognize the combination of pacing on the ECG and whether the markers are marking correctly, and that there is not any markers that are incorrectly denoted. If not, you'll suspect there is an issue with the lead. Okay, pacing percentage histogram will also give us a hint of the patient's implant indication. A high percentage of V-pacing shows us that my patient might be having complete heart block, whereas high percentage of A-pacing could be an indication of patient with 6 sinus syndrome. It will also be good to compare with past device check results and trends to see whether there's any significant difference in the pacing percentage trend. This may be an indication that the patient's sinus node or AV node might have deterioration, and if so, we might need to review and readjust the parameters to suit the patient's current needs if the patient has increased in pacing dependency per se. Okay, next, the favorite question asked by my patients will be, how long more can my pacemaker last? It's also important that for the most simple reason is we don't want the pacemaker to run out of battery and have the patient fainting on the street, and also give us ample time to schedule for a device change out. So there are many different terminologies used among the different device company to indicate like what is the remaining battery longevity. So the term is actually 3 to 6, there will be a 3 to 6 months window for us to schedule for pulse generator changeout. So this period is considered as elective replacement indicator, known as ERI, or the recommended replacement time. Okay, so within these 3 to 6 months, it's important to us to take note and to schedule for a nearer follow-up date to meet the physician to discuss when to do a pulse generator change. I'm also quite naggy at times. I will let my patient know that they have to come for their appointment regardless of what, because their battery is depleting. Because I do have patients who are the type that will actually forfeit and not do follow-up. So sometimes I act as like a nagger in this instance to just warn them and remind them to take note of their visits. Okay, so all the different devices will provide batteries in different manner. Some may be graphical, or some might actually just tell us literally how many months or years the device is left. And often they are a measure of battery voltage, impedance, and current drained. Okay, so being someone who do device checks or different programmers, we have to make sure that we know how to recognize and read battery remaining battery longevity. Okay. However, do take note that all these are simply an estimation. It might actually change depending on the usage and output subsequently. Okay, this is a very useful table on the information of different magnet modes from the different device company to help to identify whether the device is in ERI or end of life. Oh, sorry. So you can actually use the magnet road to help you by placing a magnet over and just using an ECG machine if you do not have a programmer around with you. Okay, so like to feature about this in Medtronic, that during ERI, there's actually even a mode switch from dual chamber pacing to BVI 65 for them to conserve the battery. But on one hand, this will actually cause pacemaker syndrome in some of our patients, and they'll feel symptomatic. So this is something to take note of. Moving on to lead monitoring checked. So lead impedance is actually an important diagnostic tool for us to verify the integrity of the pacing lead. Okay, a typical range will be between about maybe 200 to 2000 ohms, but for me, my threshold will be actually higher, like maybe between 300 ohms to like 1008. So like Shufa has mentioned earlier, okay, a low impedance might indicate an insulation breach, whereas a high impedance is indicative of a lead fracture. We should also compare with the trend and historical data to make sure that it's actually a stable trend. There's no unstable or fluctuation in the values. Any deviation that is more than 30% to me will be suggestive of a fracture or some other lead issues. So in this example, the current lead reading seems to be within the normal range of about 1000. But however, if you compare it with the trend, you can see that there is a significant jump from 400 ohms to 1000. So to me, this might be an alarm bell, and I will probably alert it to the physician to maybe rule out lead fracture by asking the patient to go for a chest X-ray. Hence, like I said previously, it's important to look through all the histogram and trends when we do a check to make sure that they are pretty much stable. Stability in all these measurements will help to indicate that the device is functioning properly or there is not much changes in the patient's clinical condition. Okay, moving on to sensing and threshold check. Sensing test is useful to find out a patient's own intrinsic rate and AV conduction. And it can also determine whether the current parameters need to be adjusted to encourage for more intrinsic rhythm if necessary. We can also look out for potential undersensing or oversensing issues. So how do we perform a sensing test? If the patient is pacing at that moment, I will lower down the rate to maybe DDD 30 and stretch the AV delay to do a sensing test. If I'm still unable to get R wave sensing, I will then proceed to change the mode to VVI 30 bits per minute. During this time, I'll make sure that my patient, especially for patients with complete heart block, they are not feeling any form of discomfort, and also ensure that a crash cart is nearby should we actually unfortunately induce bradyinduced torsade. Okay, so while we can do sensing measurements during our in-office check, our devices are also very smart. They can do auto self-check and automatically adjust the target safety margin accordingly. So the safety margin for sensing and P2O to make sure that there is at least 2 times of the safety margin or the sensing margin. So this will having this intrinsic sensing measures will actually ensure that there's periodically update and readjustment of safety margin for fluctuating sensing results, which is actually safer for our patients, because sometimes it will take them about 6 months to 1 year to do our in-office check. By then, if there's anything wrong in the middle, or you'll be too late to just simply adjust our sensing value. So I will discuss some of the sensing issues that I commonly might meet during the device check. One of the most common issue will be undersensing, which is simply unable to sense correctly any intrinsic signals, causing inappropriate pacing. So example will be this, where there's undersensing of fine atrial fib waves. So undersensing of fib wave will not allow for mode switch from DDD to DDI. So for this issue, we will just increase the atrial sensitivity to a lower value to allow fib waves to be sensed. In another example, so just take a look at this strip. You can see both A-sense and V-sense marker. However, is to take note that the R wave is actually inaccurately sensed. The V channel is actually sensing the atrial signals instead. So we should actually suspect whether there is actually a RV lead dislodgement, and also compare with the rest of the test results, such as threshold and impedance, and of course to alert our doctors to do the follow-up. Okay, Another sensing issues will be oversensing. Okay, oversensing occurs when the pacemaker is inaccurately sensing other signals, hence inhibiting pacing. So one example will be sensing of myopotentials or sensing of lead noise. So for this strip, seems like the pacemaker is sensing a lot of activity on the ventricular channel. So we need to investigate more to find out whether there might be a potential insulation failure on the lead. Underpacing resulting from oversensing is actually dangerous for patients who are dependent because it might actually cause them to have asystole. Another example will be T-wave oversensing. So for the atrial lead, we can see that it's actually able to pick up the far-field T wave as well. So what we can do is simply to adjust the sensitivity to blank out the T wave. Okay, just in a nutshell, there are many different reasons that's causing undersensing and oversensing issues. We need to identify the cause in order to apply the correct method when troubleshooting the issues. So it can be as simple as pre-adjusting the parameters such as sensing amplitude or blanking period, or in severe cases, the issue is not with the parameters, but it could be due to lead fracture or dislodgement. So what I will do is when I have issues with audio sensing, I will check in both bipolar and unipolar configuration and also perform a provocative test to rule out whether there's any noise. So if the other vectors, such as maybe unipolar sensing is good, I might actually suggest the physician to change the sense configuration in the meanwhile if the bipolar sensing fails. Following an implant, there will be this lead maturation process during the 3 to 6 week period. So lead maturation is actually an inflammatory reaction that is produced after the lead tip is in contact with the endocardium after implant. So during this 3 to 6 weeks, the lead, there will be unstable readings of, there might be unstable reading of sensing and threshold results. So during the chronic phase, then the sensing and threshold results will actually stabilize and improve. So on my side, how do we adjust the settings? During these 3 to 6 weeks post-implant, to minimize the probability of non-capture, we'll just leave the output of both the atrial and ventricular output to a high output settings. Then when after like the subsequent checks, when the readings are more stable, we can actually reduce the output and on auto capture management once it has stabilized. So generally, we'll set a safety margin of 2 times the amplitude of threshold and 3 times the amplitude of pulse width. Adjusting the pacing output and for safety margin is important, but at the same time, we do not want to unnecessarily waste battery life. So device having such as auto capture and auto adjustment is actually useful as they can help to lengthen the battery longevity by 1 to 2 years by simply lowering down the output from to lower down by 1 or 1.5 volts. This will be useful for patients if you realize that their readings have been stable for a period of time. Then I think it will be actually safe to just on auto capture for them. Okay, so after doing all the routine checks and measurements, it's important to also look through and verify whether there's any clinical episodes that are recorded in the device. So these are some of the common ones that are listed, which is ATAF episodes, mode switch episodes, whether there's any PMT episodes or any high ventricular rate or atrial rate to suggest whether there's any arrhythmia such as atrial flutter or frequent PACs or AF. So using this illustration, this component is useful to tell us a story of the patient's existing arrhythmia issues. So this mode switch will give us an indication of how frequent and how long patients is having episodes of probably AF, and the ventricular rate during atrial arrhythmia will give us an indication if patient is in AF, like how fast can the rate go out to. So the doctor might actually refer to it to see whether they will want to adjust or prescribe beta blockers. And over here is also, we can note that there is an onset of atrial arrhythmia episodes, which wasn't previously documented before. So it's also useful for us to discover patients with new onset of AT or AF, and in return, we can actually start on anticoagulation therapy as fast as possible. So other than looking at the trend, we need to open up the EGMs that is stored, if there's any, to verify that it's an accurate episodes. Sometimes the EGM will actually show something such as oversensing, which actually, or undersensing, which actually highlights that there is other issues with the lead, such as probably like lead fracture. Okay, likewise for this example, we can appreciate that patients originally has paroxysmal AF, but from the start of November, their AF burden has resulted to 100%, which is a transition from paroxysmal AF to pulmonary AF. So in this case, we might, the doctor might actually suggest whether there is a need to do a switch from DDR to a permanent DDI for the patient. Okay, following on, I'll look through all the trends as well. So one of the different trends we'll look through is the heart rate histogram. The pacemaker is designed to mimic the human heart, so it makes sense to expect like higher ventricular rate pacing when exerting or doing exercise. So an ideal situation for a histogram were to see a staircase distribution to indicate that there's a fair distribution to support patients' daily activities. Okay, in this example, one of my patients who indication is complete heart block has benefited from owning the rate responsiveness. So before that, the rate responsiveness was on, and you can see that the histogram is just consistently pacing at probably like 60 beats per minute, and he is symptomatic and complain of breathlessness during his morning walk. After owning the rate responsive mode, during the follow-up check 6 months later, I'm happy to note that there is actually a staircase distribution, and he is no longer symptomatic and is able to do more physical activities without feeling breathless. So I have summed out a table of the rate responsive parameters that are by the 4 different device company. So basically, they use on two types of indication on how to respond. One is via the activity sensor, which is the accelerator, and the other one is by lead impedance base. So the first one, activity sensor, will offer a rapid response to exercise when the moment is assessed body vibrations or movement. So, and also they can be further adjusted to make it more responsive or less responsive according to the patient's needs. Lead impedance base, such as sensing from the myocardial impedance within the lead itself, or transthoracic impedance, are useful for patients whose indication are vasovagal or sinus node dysfunctions. So we can consider using these parameters to customize them according to their needs and indications, while ensuring that there's sufficient pacing for patients with complete heart block. We should also try to reduce unnecessary pacing and promote intrinsic rhythm for patients with intact AV conduction. So before any check, I'll also ensure that the AV delay is appropriately stretched for those with intact AV delay, such as switching on the hysteresis, rest mode or sleep mode to customize it. Lowering the battery output after the acute phase of implant is over is also useful in extending the battery longevity lifespan. So these are the features that I can remember offhand by the different companies that use to enhance and promote intrinsic rhythm. So one of the method is extending sense AV delay, and the other method will be the mode switch method, whereby if they sense that there's intact AV conduction, it will no longer be functioning under the DTD mode, but it will be switched to AAI or ADI, where it will just be primary atrial sensing. But of course, there will be also a backup rate of VVI or mode switch back to a DTD in the event that the device realizes that there is no V stance followed by the A pace conduction. Okay, so towards the last part, one of the troublesome thing that I face is actually episodes of PMT, which is pacemaker mediated tachycardia. Okay, it is sometimes seen in certain patients, especially those with intact VA conduction. So pacemaker mediated tachycardia, also known as endless loop tachycardia, is actually a reentrant tachycardia caused by the pacemaker when they are tracking in the dual chamber tracking mode. So patients with intact VA conduction, it was caused by the retrograde pace or P waves that is being sensed, and hence it was being tracked, followed by a pacing. So this pacing will in turn cause another retrograde P wave, and it will cause a reentrant loop that will cause it to, this cycle will continue with tracking of the retrograde P, and it will occur usually at the upper tracking rate. This will be very uncomfortable. So imagine a patient will be pacing at the upper tracking rate of 110 to 130 beats per minute. So how do we recognize whether a patient is currently in PMT or whether it's simply because the atrial rate is very fast? Is when we place a magnet over the pulse generator side or revert back to a single chamber mode, the episode will actually terminate. What are the ways that we can do to actually prevent this type of PMT episodes from occurring? Okay, one method will be to extend the PVAC and to on any PMT algorithms by the device to reduce the number of PMTs in the patient. Okay, so we can actually extend the PVAC manually during in-office check by measuring the VA conduction time. So we'll pace it at a VVI rate that's faster than the intrinsic rate to force it to pace, and to measure the pace V to the retrograde A. So example, if this value is about 270 milliseconds, we can manually extend the PVAC by another 50 milliseconds so that it will cover, it will actually extend out and will not be able to read the retrograde P should another episode occurs the next time. So to test whether my PVAC is sufficiently stretched, I'll redo a threshold test to see whether it's inducible. At the same time, we can also make use of the features of the device algorithm to monitor for any subsequent PMT checks and whether to terminate it when they actually auto detect PMT. So this is a summarized table which I think is very useful of what are the different companies and what are the features that they actually offers for PMT algorithm. So the three methods that they use to terminate PMT, or the concept of terminating PMT, is extending PVAC, extend PVAC after every PVC, or atrial pacing after PVC. So an example that's used, this is the Medtronic street. So the Medtronic actually has, it actually senses and determine that this is a PMT episode, and it, after the number 8 or 9 beats, it will auto stretch the PVAC to 400 milliseconds and to try to interrupt the PMT if there is once. So this is an example of how the algorithm works. And another example will be this APHRS shift, whereby the device accurately denote that it's a PMT, and it also will trigger extension of PVAC, and it will cause it to terminate the tachycardia. Okay, finally, this slide serves as a personal reminder to me that even though we are so busy with checks sometimes, it's also important not to neglect the paperwork process. So proper documentation of test results or lead details or the patient's history or any existing alerts or advisory will help us to ensure that there's a better handover to whoever who is doing the check subsequently, as all these checks will actually tell stories to the patient's condition. Okay, thank you. I'll end off my lecture now, and please stay for the next segment because there'll be a quiz on a series of case study. Thank you.
Thank you, Sui.
Thank you, Sui. I think very nice talk and very simplified way you elaborated the post-implant check as well as the basic troubleshoot, which is, I think, is very important to know each and every technical stuff, right from the pacing parameter, sensing parameter, lead check, battery status, and some troubleshooting like PMT. And very important nowadays is to look at for the silent AF burden in these patients, because nowadays these devices, they can help us to look at the subclinical atrial fibrillation burden in these patients. And I think in next couple of years, it's going to make change into the recommendation of use of anticoagulant in these patients. You have elaborated very nicely in the quick look that one should check the lead parameter if there is a sudden change in these parameters that makes you alert that what suddenly happened to these patients though they are asymptomatic, so that timely intervention can be taken before the patient become too symptomatic. Dr. Park, your comments, please.
Yeah. Ms. Shui Ho, thank you, Ms. Shui Ho, for your nice presentations. Many aspects of device follow-ups were well addressed by these presentations. I'd like to ask you some questions because recently so many diagnostic and even therapeutic functions are beginning to incorporated into pacemakers. So sometimes we need to check many aspects of pacemakers. So how many minutes, for example, how many minutes can you spend for this device checkup for one patient in your hospital?
My device, our clinic site has a high volume of device. So looking at the trend, we actually have a proper system whereby we will document on our site what are the previous checks results. Okay. Hopefully we always cross our finger and hope that it will be a routine device check. But of course, if there's a need for troubleshooting, I do not conform myself to a period of like, okay, 10 minutes per patient. If there's a need to, we do spend sometimes up to 10 to 30 minutes because we do not want to do a check simply for to keep within the time frame, but to ensure that that is actually correctly addressed. So the period of time will depend on how simple or how complicated, or whether we find any problems or issues in the device check. Yeah.
So one more question, please. Remote monitoring become more and more important recently. So is a remote monitoring system available in your country or not?
Yes, it is for a few years now, and we are seeing a very high volume. In fact, it actually is a strain on our workflow because on top of doing an in-office check, we also have to look through home monitoring checks, like online. Okay, but I have to say that even though it's tedious, but it actually is able to pick up a lot of early issues. Because sometimes if there is any issues with the lead, the patient is still okay. They might not feel it. So the only indication for them to feel something is they feel uncomfortable. So for this patients who are asymptomatic, home monitoring is useful in picking up, or example in ICDs or ICD or CRTD when there is a shock. We'll call them up as well and ask them to come back to do a check or to admit themselves. Yeah, I think recently Shufen has seen a few issues regarding like maybe lead fracture or something as well.
Yeah, but recently my patient with a lead fracture came in because of the alert tones. So Medtronic, they have the sensing integrity counters. So that hit the limit, and there's an alert tone, and he came in. So I think that with the home monitoring, it can be very useful to detect all these issues earlier, so that they don't get inappropriate shocks, because it can be quite traumatic for the patient.
I think you have answered. There was one question that somebody want to hear opinion on telemedicine. I think this answered the question. There is one very interesting question from the audience, that I have a pacemaker patient with DDDR implanted for complete heart block. ECG picked up AF, but not noted during pacemaker interrogation.
Oh, okay. I was taught that DDDR mode will be okay to pick up any mode switch, but that might be because of what I said earlier, that there might be under sensing. I mean, I think I covered that in one of the slides. But if it's in the DDI mode, I don't think it's able to pick up mode switch. So, Dr. Bali, could you help me in this question? Yeah. I'm also not very sure.
Okay.
Yeah.
Dr. Park, your comment, please.
Yeah, I thought that DDI will be the one that is unable to pick up.
So I also think that under sensing may be one of the most important problem.
And sometimes if your AV delay is complete heart block, so AV delay shouldn't be stretched. But if you have very long AV delay, very long PVAP intervals, so these are the intervals which actually blank out the A. So if you have long AV delay, long PVAP intervals, you might actually reduce detection of AF, because your A waves are being blanked out.
Yeah. That's very appropriate, Shufin. But in that case, you may miss certain part of AF, but you cannot ignore it completely, even if your PVAP or AV delay is long. But I think Dr. Park has mentioned that if there is some sensing parameter need to be readjusted, because this is a quite unusual situation. Most of the time, it is the other way around, that you picked up the AF because these devices are quite sensitive to pick the subclinical AF, rather than which are missed by most of the time on the Holter or the surface ECG. So I think let's move on to the next part, your quiz session.
Oh, can we go back to the home monitoring? I would like to ask everyone's opinion. Do you find that home monitoring actually sometimes have too much information and we are a little bit overwhelmed by the information?
Like, from the doctor's physician point of view, like, will you recommend home monitoring for all patients or selective patients?
Yeah, in India, we have introduced this in last couple of years with the certain patient who usually come to our center from a very remote area. And it is not possible for them to come for the routine checkup at every 6-month interval, because they are living in a remote area. So especially the patient who are dependent on the pacing, or when we are implanted the AICD because of the secondary prevention, we know that there is a documented episode of the cardiac arrest. So in these two subgroup of the patients, we recommended them to be on home monitoring to be on a safer side. You are very right that because of the so many, as Dr. Park said, that nowadays there are so many parameters incorporated into the devices to make them so complicated. And sometimes the patient is so anxious about all these things that they want to call you again and again and again because of the certain alerts. So it's very difficult sometimes to. So it's basically patient education to tell them about these. But I fully agree that sometimes they create a lot of nuisance and lot of false alarm because of these lot of algorithm incorporated into this. Dr. Park, your experience in this?
Unfortunately, remote monitoring system is not available in Korea because due to some political issue. So actually, technically it's possible, but political issue prevent us to use the remote monitoring system. But I hope this home monitoring system become available in Korea as well in the near future. So our government trying to, Korean Heart Rhythm Society is trying to adopt this new useful system. So therefore, I have no experience the home monitoring system, but I think this home monitoring system is very useful for the early detection of problem, patient with problem. So, and issues like too much information can be surely can be resolved in the near future, because many technical advance can solve this problem as well. Because for example, artificial intelligence, for example, machine learning can probably will be adopted this pacemaker. So this kind of issue probably can be handled successfully in the near future, I think.
Okay, we go on to our little quiz.
I think this is a blessing in disguise for Dr. Park, that because of certain political reason, they don't have this home monitoring system. So till then, you can enjoy your practice safely and peacefully. I think till okay, Shubhen, we start the quiz then.
Okay, so we had 3 patients, and let's help to see what they have. So our first patient is a 79-year-old lady. She has a pacemaker, dual chamber device implanted for tachybrady syndrome. So 5 days post-implant, she came to the emergency department with chest pain and cough. Okay, this is pre-COVID. So this is the threshold results. So atrial threshold results. So you can see here, this is the threshold results, which is very, very high compared to just 5 days before, 10 times higher. And I think even at 7.5 volts, there's non-capture. And for sensing here, it's intermittently not really sensing, or sensing funny things, but it's not too bad, I guess. Although you should notice that this is a unipolar and this is bipolar. So we look at the atrial impedance. It has been quite within range, except for one time that it went out of range. Would Professor Park and Dr. Malik, would this alarm you? And this is the electrogram that the patient came in with. So this is the atrial electrogram, ventricular electrogram, and then the markers are below. And patient has lots of auto mode switch entries within the past few days. Okay, so what do you think is the problem here? Could there be a lead dislodgement, lead perforation, and insulation breach, or do you think there's a need to do X-ray to further help you in this? I think we gave like everyone 30 minutes to have a selection. Oh, sorry, 30 seconds. So, Professor Park and Dr. Malik, do you think we need more tests, or you sort of have a clue what this patient have?
Yeah, let us see the audience poll. What do they think?
Okay.
Let us see.
Okay, everybody wants to do an X-ray for the patient. Is that the same for everyone? Okay, so let's do an X-ray for the patient. So on the left is the X-ray, post-implant, and now this is the X-ray that we have. So is this quite definitive of what you think it is?
Is it a real patient, Shubhan?
Yes, it is.
Yeah.
Yeah.
Jimmy, do you have? Yeah. Okay, so let's see if we are all on the same track. So lead dislodgement, lead perforation, insulation breach, or okay. Yeah, I see if I can show the X-ray again. It is quite obvious, yeah, on the X-ray, I guess. Okay, wow. So everyone is quite good. Oh, it's really, yeah. So it is lip perforation, and in the end, we did go into the OT.
So this is after how many days after previous implant?
5 days. 5 days post implant. Okay. Yeah. Okay. So it actually perforated out into the lung. Yeah, that's why patient had a cough when she went to the A&E.
And there was
how old was the patient?
I'm sorry, again?
How old was the patient? Can you tell me what?
79.
79.
Yes.
79.
Yeah.
Female or male patient?
Female.
Female. Okay.
Yeah. So is that
personally, I experience a perforation case usually in old female patient like this. So RV perforation or RA perforation usually in old elderly female patients when I use active fixation. So I think we need to pay more attention to the possibility of lead perforation. We perform lead implantation using active fixation, particularly in old female patients.
Okay.
And there was diaphragmatic pacing also noticed
during the implant
after
or
this?
After? No. The post check was absolutely normal. Yeah, only when she came to the emergency department, then
okay. Can we see the X-ray again, Shubhan? The X-ray slide. Yeah.
Okay.
Very nice.
For us. Yeah. So
what, how did you deal with this patient then?
We did an extraction in the OT.
Okay.
Yeah, because the perforation was quite far out. We did a CT, so it showed that the lead was already into the lung. Yeah, so we did an extraction in the OT.
And did she require any hemodynamic support once you pull out the lead? Was there any tamponade or like this kind of thing? You remember?
I think it was okay. Yeah, there's even for the past few cases which it did perforate, some of there wasn't a huge amount of effusion immediately. Yeah, for now, so the few cases that we have.
Okay. Your experience, Dr. Park, in such kind of cases when you have perforation in the atrial lead in comparison to the ventricle lead?
Okay, so ventricular perforation usually occur in RV apex. So we very careful. So when performing the RV implantation, we try to avoid the RV apical implantation. We implanted RV lead because, as you know, RV apex is very thin. So we prefer implanting the lower septum or alveolar area to the apical region. So RV perforation usually apex. So, but as you know, our right atrial perforations can occur because right atrial wall very also thin. So RA perforation usually occur when we use active fixation RA lead. So when we afraid of RA perforation, we can choose passive fixation lead. But so as to the pericardial effusion, the risk of pericardial effusion or tamponade are relatively low when RA perforation because RA pressure usually low. So tamponade or pericardial effusion usually occur when we pull out, when we extract the RB perforation. RA perforation usually not lead to significant tamponade or pericardial effusion.
Okay, we go on to the next patient. So for this patient, the device has been implanted for 8 years, and the patient comes in for a usual follow-up in the device clinic. And I've highlighted for you what you should be looking at. So as you can see, the device is nearing ERI or effective replacement indicator. So here you have the impedance, which is really very, very low. And then patient has got lots of AT events caught on the device. And when we look at the events, you can see the rates are super, super fast, which is totally not physiological. Even if it's atrial fibrillation, it should be about 200. Yeah, this is 700 beats per minute. It's very, very fast. And you can look at the electrograms. Something is not quite right here. So low impedance and noise on lead. And again, Sui has told us we must look at the trends. And the trends have an indication of the impedance. So atrial impedance, this is the rest are the ventricular lead parameters. And so what is the problem here? So we have lead dislodgement, lead perforation, insulation failure, or do we want to do an X-ray again for this case? But this should be quite, we should have quite a conclusion already from the check, I think. Wow, okay. So they have been listening to you.
Yeah, so, glad to know.
So yes, this is an insulation failure. So the last patient might be a little bit tricky. So the congenital is just to throw you off. So it's a 57-year-old lady with a CCTGA, congenitally corrected transposition of great arteries. Okay, she developed complete heart block with episodes of syncope. So we implanted CRTD for her, and she was placed on home monitoring. So this is the check that she came in post-implant, and everything looks very good, right? You have your atrial capture here, which is all very good output, low. The sensing is not too bad for a congenital heart disease heart, and the impedance are all within range. And IV pacing, we would want it to be almost 99%, but she's got 93%, but it's okay because she's got some PVCs, so that might be accounting for the slightly lower by then pacing. Okay, so 2 weeks later, she came and reported that her heart rate was lower than the lower rate that was set for her. So sometimes I do tell the patient what the lower rate that's set for them, so that at least they can keep track. If their heart rates fall below that, then they know that there might be an issue with pacing, an issue with their device. So on arrival, the ECG showed complete heart block again with a ventricular rate of 55 beats per minute. And now you can see the capture is fine, but atrial no longer senses. Your RV sensing is also dropped to 1.3, which is very, very small. Impedance seems fine. Okay, IV pacing has also dropped because of that. Okay, so do you think we can conclude with just the electrograms here? Oh, no electrograms, with what the history and everything. What would you like to have more? Or do you think we can conclude it's a lead dislodgement? Or yeah, IV pacing has dropped because there's just too many PVCs. Or would you like to look at an electrogram? Or would you like to do an X-ray for the patient? Okay, most would like to look at the electrogram. So I have it here. Okay, here you are. This is the electrogram. So you have the markers on top. So the markers tell you what the device is seeing. So the device is telling us it's seeing a lot of B-sense and no atrial sensing at all, except occasionally. And this is the surface ECG here. Atrial electrogram is here. And on atrial electrogram, you can see actually there are atrial signals. But when you go up, it's actually telling you it's B-sense. And for your B-sense, it's on the same timing as the A-sense. So you are starting to have a conclusion what this might be. Okay, so we actually did do an X-ray for the patient. So this is the X-ray here. I think now we can conclusively tell what happened to this patient. So is it a lead dislodgement? Again, a lead perforation? Oh, let's hope not too many perforations. Insulation bridge, or a lead header switch. Wow. Okay, so this is the last patient. Any comments from our doctors?
I think Shufan and Suya, your job greatly done, because the audience has responded in such a nice way to all your quiz. It's, I think both of you have explained the basics of the pacing and their follow-up so nicely. I was seeing that most of the time there were almost more than 85 participants attending this seminar. And heartiest congratulations to both of you for your fantastic work and hard work. You have put your all effort in the basic teaching, and with these 3 fantastic cases showing a basic troubleshooting in this. Dr. Park, your comment, please.
Thank you for your good presentation and good chair moderation. So I think today's topic will be very helpful for the better management of patient in many hospitals for many patients.
Thank you.
Thank you very much. And thank you to the audience as well.
Yep, if there are no more questions, I would just like to share. We have this webinar series almost on every first Saturday of the month. So we would be alternating between EP topics and pacing topics. So I'll be happy if you guys would like to join us again. Yeah, so we are running late. So thank you. Thank you everybody for coming.